Hi, I'm Dr. Jeffrey Antimarino from Bazley Plastic Surgery and Spa. Welcome to our Facebook Live event. Tonight, we're going to do something a little different than what we've talked about in the past. In the past, we've usually talked about procedures that I do. But tonight, as many of you might know, we have launched a menopause makeover on our website. And my guest tonight is Dr. John Bazley, who is one of my really good, one of my better friends. And I don't know if he'll admit to it, but he's one of my best friends. And we were in medical school together. And he's a gynecologist up in Wisconsin. And he helped us with some of our menopause makeover information. So tonight I wanted him to be on the call with me so that we can bring to light some of the information that you might want to know about menopause. Menopause is something that hits every single woman at generally the late 40s and 50s. But I'm going to let Dr. Bazley talk to you a lot about that. So welcome, John. It's so good to see you. And it's been a few years since we've actually been in the same room together, but I guess this is as good as we get in the COVID years.
Exactly. Well, thank you. Yeah, it's great to be here, and thanks for inviting me, and love to talk about some of these things. I think there's a lot that can be done to help women. As you mentioned, menopause is hopefully a problem that occurs for all women. Hopefully all women reach that age where they become menopausal, and then will spend more than half their lives postmenopausal. So God willing, everybody lives long enough to be in menopause for a long time.
Well, I know some women that are going through it that may not feel that way.
well, but we can help. So the average age of menopause is 51.3. And obviously the way you get an average is there's some folks who will enter menopause at a much younger age. There's some people who will be older. My poor mother was 58 when she went through menopause. So until you're in menopause, you do have to worry about pregnancy unless you're doing something else to permanently control that circumstance. So I still have women on birth control into their mid 50s. But in general, you should be thinking about menopause symptoms occurring in the early 50s, and the hallmarks of menopause are hot flashes, night sweats, vaginal dryness. Those are the three big issues that are symptoms that can be quite distressing, can certainly have a major impact on women's lives, and typically are the number one reasons why women will come to me and seek treatment for it. So variety of things go hand in hand with that, whether that involves physical changes, mental changes. We know, for instance, that there is a significant change in mental acuity after menopause. And certainly there can be social issues that will accompany this. So I'm happy to delve into this and give you guys a little bit more detail on the nuances of it.
Good. So tell me about, because we're going to jump into all of those, especially the hot flashes, the night sweats, some of the emotional ties to it. But so there's also this perimenopausal. So explain kind of to everybody what that means. And that's usually a lot of women start around the late 40s.
Yeah. So that's really kind of a tough thing, because peri means around. It's sort of an artificial term, and it doesn't really help in general from a clinical standpoint, because you either have symptoms or you don't. Menopause, by definition, is the time in a woman's life after her last period. We don't establish that diagnosis until it's been a full year since the last period. So it's always a diagnosis in retrospect. Now, yes, people can have hot flashes, night sweats. They can experience vaginal dryness at almost any age, and they may still be having periods. but that requires a little bit further medical workup. We need to check and make sure there aren't any thyroid abnormalities, some other medical reason why those symptoms are occurring that may not have anything to do with menopause. From a time standpoint, yes, if you're in your mid 40s and you're experiencing these symptoms, we may consider things even like birth control pills, which will help stabilize things, especially with irregular periods. But if it is truly periods have ceased, regardless of the age, then that is menopause.
So how many women, so let's get into the sort of the big, things that everybody sort of is the most common things that we talk about when we talk about menopause, and you mentioned them before, the night sweats, the hot flashes during the day. How many women, what's the percentage of women that experience it? Because we can see there's a big range. Some women go through menopause and with have very little symptoms. Some women are so severe, and then some women are just sort of hit and miss. But kind of take us through that.
So it's sort of a bell curve. Most people are going to have some symptoms, and most people will have some level of distress over those symptoms. Obviously, there's some people who are absolutely miserably, severely affected. I've had people who were so terribly affected, they really couldn't function, could not work, couldn't enjoy any of their normal activities, either with family or outside of the home. And then there's, as you said, there's other people who blow it off and say, hey, it never bothered me a bit. I think from general medical terms, we always kind of worry about the extremes. The folks that had never complained of pain, that's a problem. And then the folks who complain of every single thing that is bothersome, it's very difficult to fix. Fortunately, with menopause, the severely affected people are some of the easiest people to fix because we have treatment options for them. And the majority of what we do treatment-wise for those folks really, really uncomfortable is based on hormonal replacement therapy. There are a couple of other alternatives, but hormone replacement therapy remains the mainstay and the gold standard of treatment for it, and works quite well.
So a lady is now having problems with, basically it's the fluctuation where she's now having decrease in both of estrogen and progesterone. So that's what her body's going through, correct?
Correct. And it's primarily the estrogen deficit that is the driver of the symptoms, and that is controlled in the thermal regulators in the brain. And whether or not folks are really severely symptomatic or not is uncertain why that occurs, but there are those people who are quite uncomfortable.
So and that's what the hormonal replacement is, really to help increase the sort of that level of estrogen to sort of, so it's not fluctuating so badly, so you kind of smooth it out.
Right. You're trying to increase that estrogen level to decrease the symptoms. And that is dose dependent. Most people do well with fairly middle of the road dose. Occasionally we have to increase the dose.
Okay. And then, but I know there's some women that are worried about doing that. So what's we know the upsides is because their symptoms are going to go or be better managed, and some may just go away. What's the downside?
So the downside to estrogen, and there's only one real downside to estrogen, and that is increased thromboembolic events. In other words, blood clots and stroke. So that risk is real and it can't be ignored, but the risk is fairly low, and people need to know what the specific numbers are in order to make an informed decision. When we counsel people based on two factors. One is the severity of the symptoms, and the other is whether or not they have had a hysterectomy. And the reason that that's important is because the other effect of estrogen is it can stimulate the lining of the uterus, which can, left unchecked, lead to an endometrial or uterine cancer. So for women who've not had hysterectomy, they need to take a combination of hormone replacement therapy, which is a combination of estrogen and progesterone. For those women with hysterectomy, they can take estrogen alone. And the counseling then is dictated based upon whether or not that has occurred, and then we specify the risk factors based on that. So I'll be happy to go through the details on each if you'd like.
No, I mean, but
takes a little bit of time.
yeah, but I think, well, what I wanted to do is really just put it out there, because I think there's a lot of misinformation, and because patients will come into me and talk to me a little bit about it, and I always have them talk to the gynecologist, because that's just something, I mean, as a plastic surgeon or anybody outside of the OBGYN community, I mean, we know the basics of it, but, to really cite numbers and to really counsel well, I mean, it really has to come from your specialty. So I just wanted a lot of ladies to kind of understand that. And, I always try to tell my patients there's safety in numbers. So when patients come in and they're having specific problems, and I see it every week, then, I like to let them know that, yes, you're one of many women that are going through this, because it also, there's an anxiety about this is only affecting me. And then when they realize it's pretty common and that there's help available, I think that, the anxiety goes way down. Because I think in this population of patients, the anxiety and even the depression is higher. So is that really affected by estrogen, or what's the combination of psychological depression and those kind of symptoms?
Yeah. Well, depression is so common in this day and age too, and how much of that is due to many other circumstances. But when you see an acute change after menopause, then I think you have to presume that it is due to the hormone loss. I have, there's case examples that we can all go through as docs and remember the specific ones. I have a specific memory of a woman who came in and said, look, I'm ready to kill my husband, and I have a plan, and I know exactly how I'm going to do it. And I said, we need to treat you right now. This is important. And within 2 weeks of estrogen therapy, she was better. So there is, I think, a definite impact of hormone change, especially when there's a sudden hormone change, that we can really intervene and correct. And the same is true for all the other symptoms. As I said, the hot flashes, the night sweats, the vaginal dryness, estrogen replacement makes all the difference in the world, and it makes sense. Many women don't have the courage to actually take it. And that goes back almost 20 years now, when the big studies were being done, and they closed those trials early because the news took a hold of this, and they scared everybody and said, hormone replacement therapy is killing people. And they cited all of this increased risks of death from heart attacks and strokes. Well, the problem is that they sealed the records, and it took until 2013 before they re-looked at the data. And the data got reopened, and the trial studies had numerous issues with that we've now clarified the details of. And it really is coming back full swing that estrogen and hormone replacement therapy is a positive for people. But it's very difficult for the general public to forget, and it's difficult for doctors who went through training at that time to get up to speed with the fact that really we are able to use these therapies, and we're able to use them safely. And here's some numbers. The death rate from hormone replacement therapy was 18 per 10,000. That's 1.8 out of 1,000 and 0.18 out of 100, which means there's a 99.82% chance that you're not going to die from these issues. And it also turns out that the heart attack risk was true only in the first 6 months of therapy. From 6 months to 12 months, the heart attack risk was nil. And after 12 months, the heart attack risk went down. And the problem with the study was that they did not exclude anyone with prior illness, meaning anybody with a prior heart attack, stroke, high blood pressure, diabetes, kidney disease, liver disease. It was included in the study. And in fact, they changed the title of the study that said healthy postmenopausal women, and they changed it to postmenopausal women. They removed the word healthy because they were required to midway through the study. And the average age of entry into the study was 63, which means that women who entered the study on average were over a decade past menopause, which put them in a much increased risk for all sorts of other comorbidities and problems.
Right, just due to age and everything else.
Just due to age. So when we treat people in their early 50s, right when these things start, we're actually getting started with treatment at a time when their risk is lower and they can be on the hormone for an extended period of time without increasing that risk. So some new information that is kind of exciting is that it looks like transdermal options, the patches, do not seem to increase the thromboembolic risk. So oral agents do, and that risk is actually 10 per 10,000. The heart attack risk was 8 per 10,000. But if we can really switch over to patches, we may find that even that risk goes down. That'll be an interesting thing to see as the years progress, if we really do see that lowered risk.
Yeah, I think that's fantastic too, because I think, putting a patch on and letting that go for, I don't know what's the usual duration. It changes every day.
Weekly patches, so which is really nice.
Yeah. Yeah. And it's amazing that you can do it transdermally like that, and it would actually get good levels. So, I think that's easier than trying to remember to take pills and then, there's a lot of stuff that you can actually do, the different creams that you can use just vaginally for dryness, and they're very effective as well.
Right.
Yeah.
Right. We use that quite commonly. And especially pre-surgically, I'll use estrogen cream, especially with incontinence procedures, with all of the thinning of the skin, which we see obviously externally as we age, we see our skin thin, but vaginal skin and vaginal epithelium is no different, and we see a significant change in that tissue, which is normally quite elastic and pliable, and then it loses that elasticity, it loses its tone, and it thins significantly after menopause. So yet another reason why estrogen therapy is beneficial, because it can help tremendously in maintaining continence, and certainly for sexual function, it's critical.
Well, for me, when you brought up skin, I mean, that's where a lot of patients are coming to see me, and it's sort of then at early 50s, now they're starting to see just the usual signs of aging, things in their face. They're starting to get some crepey skin around the eyes. Face is starting to start to move a little bit. The neck is starting to be affected. So, a lot of patients that will come in. And so there's things even that we can do with dermal fillers and laser therapy to help with that skin. But I also see a lot of ladies that come in sort of distraught that, they're still exercising the same, they're eating the same, and they're gaining fat pockets in areas they never had before. So a common thing that I hear is that, I'm doing everything the same, yet my clothes aren't fitting the same. And so what can we do? And so for me, there's a lot of things for the facial skin and a lot of things that we can do for body contouring with liposuction and different things like that. So we can really do the same thing and treat those areas, because what I have found is that because of the hormonal changes, those areas that you're building that extra fat along the hips and upper abdomen, and sometimes in the thighs, even in the arms, are just resistant to diet and exercise. They're suddenly now almost protected, and no matter what the woman does, it doesn't change. And then that leads to more anxiety and some depression and not feeling good about themselves. So it's a tough time. It really is. And, I talk to women about, it seems about almost every decade or every 15 years, a woman's going through some type of change in her body, and menopause is sort of the last one. So the last thing I wanted to touch with you about, and you kind of brought it up, and I think a lot of women want to know about, is bladder dysfunction, where they're having some incontinence. And we blame it a lot on, pregnancies, which we know, stretches out the pelvic floor, the bladder's not supported the same, but menopause has a lot to do with that as well. And does hormonal therapy help with that?
So it's possible. it's never going to remedy or repair a true structural defect. And as you mentioned, yes, childbirth and even just pregnancy does not require having a vaginal delivery. I've seen women with C-sections who are incontinent. So it just merely being pregnant can change it. More commonly, yes, vaginal deliveries, especially larger babies, forceps deliveries, things that required assisted delivery tend to show more issues. And those tend to show up a little bit earlier. Even premenopausally, we'll have to do some interventions and maybe an evaluation or therapy. But for those issues that are more intrinsic bladder issues, in other words, detrusor instability issues, we can find that sometimes estrogen therapy will help. And estrogen works not only on the urethra, but also on the lower third of the bladder. So there is definitely an impact on estrogen therapy for bladder dysfunction. When we're going to operate, though, it's critical to have good, thick tissue to operate with. If I'm trying to sew something that's paper thin, I'm never going to get a good repair. So pre-treating with estrogen makes a big difference. And then doing our procedures, and depends on the situation. If there's bladder prolapse versus a urethral issue versus an intrinsic sphincter deficiency, we will change, we'll tailor the procedure to the particular issues. I do urodynamic testing preoperatively for everyone so that I can design the right procedure for the patient. But estrogen therapy makes a big difference preoperatively, and in many women, it'll make a difference postoperatively as well. And the big reason is that you can then allow for physical therapists to help work on muscular control, which the estrogen is now allowing you to use those muscles and help with your continence issue. So it's a multi-pronged approach, but the key is getting the tissue to have enough turgor, enough tone so that we can work with it.
Yeah.
And that's where the estrogen comes in.
Good. Well, that's good. That leads me to my last question then. What, how do you know when to stop hormonal therapy? So not every woman is going to need it for the rest of her life. How do you know when to stop it?
So, terrific question. And the answer is, we don't know.
Okay.
And I have women in their 90s that are still on it.
Okay.
And I have no concern or qualms about doing it. And the reason that I have no concerns about it is because they have tried going off of it. They've tried lowering the doses, and they have had a resumption and return of symptoms. And therefore, for them, it's worth it to stay on it.
Okay.
So anytime somebody wants to go off of it, they can go off of it. But as soon as you do, you then begin to make those same changes, whether it's epithelial changes, whether it is mental changes. We know, for instance, that estrogen has shown a decrease in the risk of Alzheimer's and dementia. We know it decreases the risk of breast cancer. It decreases the risk of colon cancer. But a big, big factor for estrogen is its decreased risk for osteoporosis. And when you see, we've all seen the little old lady with a cane, right? And she's hunched over. I mean, her spine is like this.
Right.
She can never stand up straight. How many of those women are doing cardiovascular exercise? I mean, just walking is cardiovascular for them. They're not exercising. They're not doing the things that we all feel is a good preventative health thing. So if we can maintain health, I think we're going to maintain quality of life into our 70s and 80s and 90s, and maybe we'll be centurions. But I do not stop estrogen unless a patient wants to. And if she wants to continue it, I have no qualms about continuing it.
Okay. Well, those are good, good things to know. And I've certainly learned and brushed up on a few things tonight too. So, but I really wanted to thank you, John, especially taking some time at night to go over everything with me. And we thank everybody for listening in. And if you have any questions at all, please let us know. And you can access our website for the Menopause Makeover. And there's certainly some information in there from Dr. Bazley. So thank you again for staying with us. We'll join up again next month, and I'm not sure what the topic is yet, but hopefully it will be a good one. And Ella's shaking her head yes, so it'll be a good topic. So we'll see you next month, and I hope everybody has a really nice Thanksgiving.